So everyone, you got to know me with my little brief introduction. So as ketamine has been a hot button issue in the news, particularly related to the death of Matthew Perry, I thought it would be a very apt topic to present today. So we're going to explore ketamine, a traditional anesthetic turned novel psychiatric treatment. Here's a brief disclosure statement that I will be covering both approved uses of ketamine and off-label uses as well during this presentation. So for our learning objectives today, we are going to be discussing, oh, I'm sorry, I just lost my spot in my presentation. Pardon me, everyone. So we're going to explore how ketamine, this well-known anesthetic, is revolutionizing psychiatry by providing rapid relief from depressive symptoms and suicidal ideation. Here are our learning objectives. We're going to go over the mechanism of action of ketamine, review some approved and off-label indications, go over some evidence from key trials studying this, and go over safety considerations, monitoring, and clinical applications, and then discuss some ongoing research in the maintenance therapy. So why this topic again? I love innovation in medicine, and ketamine has actually been found to be naturally produced in certain fungal species. It's growing in field, growing in popularity, and been in the news very recently with the death of Matthew Perry. I'd like to go over a little bit of a history of ketamine use in healthcare. I wanted to note that this is personally one of the training elements I was looking for when deciding to select a residency program. Previously, ketamine is typically used as an anesthetic and analgesic agent. A lot of times you'll see it being used in the trauma setting in the emergency department. It's also used on the battlefield in conjunction with fentanyl patches for pain relief, and is used in the OR by anesthesiologists. It's a clear and colorless medication first developed for use in operating rooms. As it's growing in study, there have also been uses in PM&R pain clinics with ketamine IV infusions for complex pain syndrome. And now it's starting to evolve into the field of psychiatry as well. Also, if you find yourself ever in a med spa or a health spa, you may see that ketamine infusions are listed as an available service. This is typically a little bit more common in places like California, Los Angeles, and Las Vegas. So ketamine binds non-competitively to the NMDA receptor. It's an antagonist. It is renally excreted, and there are a lot of different methods for infusions, whether it's IV, intramuscular, subcutaneous, intranasal, and oral. And I just wanted to provide some of the different bioavailabilities for these different treatments and how much of the active form S-ketamine is going to be playing a role in potentially alleviating some symptoms. And I want to note that ketamine acts both as an upper and a downer in the brain, as it has a range of both excitatory and inhibitory receptor responses. Here's a little diagram to show you. We have both the rapid actions up on the top section where you can see the ketamine would bind to the NMDA receptors, and then, sorry. And then there's also some sustained effects modulating gene transcription, which is potentially going to provide some longer term like neuroplasticity and neuromodulation in the brain to potentially have some sustained effects. And we're going to look into this today. Here are some of the side effects. Typically very mild. It is short term resolving within 2 hours. In higher doses, it definitely creates this dissociative state as a hypnotic agent, as seen in the OR, and it does have a sedative effect, ranging from mild to deeper sedation. Ketamine also produces a dissociative state for people when they take this substance, feeling us like our mind is not really connected to our body and can be accompanied by visual disturbances. This is sometimes referred to as a K-hole for people who use ketamine in recreational settings. Given its use in the OR and the battlefield, it also has analgesic effects and helps limit the pain that people are feeling. As far as like sympathetic effects, it does have some transient increase in blood pressure and heart rate, but no profound effect on respiration rate. And then if you're continuing to use this substance for the long term, there are some of these long-term side effects. Most commonly, we're going to see this bladder retention in patients. And then there is also an addiction potential that I really want to note and highlight that today, as it is being used recreationally, and then also just the long-term effects. People might get used to it and feel more dependent and reliant on it to help them feel better and more normal. So for the theory in psychiatry, it kind of stems from if we can use this substance to alleviate physical pain, does it also help alleviate that sense of mental pain and emotional pain? So at very, very low doses, ketamine can address this cognitive rigidity and feeling stuck. So if patients are complaining about a lot of ruminating thoughts, feeling stuck in bed with their depression, ketamine might be able to help address this. And this comes from the mechanism theory of it's enhancing the neuroplasticity temporarily, mainly. And something else I want to note is that mindset is really the most important factor when it comes to the treatment of whether patients are going to have a positive effect from this or not. If they are open and engaged in this treatment and think there is hope for it having a positive effect on their depressive symptoms, it's actually more likely to have that antidepressant effect. So here are some of the current indications in psychiatry. As we can see, it's only been approved for treatment-resistant depression, this S-ketamine version. And I want to explore a little bit more about some potential off-label uses that have been hypothesized in secondary analyses of different clinical trials. Most notably, it seems like there is an improvement in acute suicidality severity of symptoms, and this is seen very early on, within 2 hours at the point of first infusion, and those effects tending to last up to about a week. There's also some instances when they were stratifying groups between bipolar depression versus unipolar depression and found that there was an antidepressant, anti-suicidal effect seen in patients with bipolar depression. There is some ongoing research still continuing on for potentially extending this use to treat PTSD and OCD disorders. So what are the risks, though? Many of us are familiar with the circumstances regarding Matthew Perry's death, and how is the coverage and the news reporting influencing public perception of ketamine and versus how it's used actually in the medical settings? Something that I wanted to share is that most people don't know that Matthew Perry was also regularly taking buprenorphine for his opioid use disorder, and there is a drug-drug interaction between buprenorphine and ketamine, which compounds the extent of the sedative properties seen. Also to note that Matthew Perry was engaging in some potentially recreational ketamine use with oral supplementation in between his infusion appointments. Given this, I want to highlight the risk of addiction, especially in those with current substance use disorder, especially if it is poorly managed. I do want to add a little anecdote that it is safe for use in current like alcohol withdrawal, and that there is no increased negative adverse effects in that particular disorder. But when combining it with a substance like buprenorphine, that's increased sedation and then the increased potential respiratory depression can cause some issues that we would want to avoid. Some known or suspected contraindications to ketamine therapy. If they're allergic to it, have ever had a hypersensitive reaction to it, please do not try and continue this in the future. Also, something to think about is the sympathetic effects, how we talked about increased blood pressure and increased heart rate. So if your patient has uncontrolled hypertension, really poor cardiac output, cardiac insufficiency, history of stroke, or even the history of psychotic disorders, I would be really hesitant about wanting to engage in this potential treatment with patients. So this study here is talking about the use of ketamine for treatment-resistant depression, which is an approved use. And of note, in this study specifically, during the different trials that they included a maintenance period of repeated dosing of ketamine, and it ranged quite widely from 4 weeks all the way up to 5 years. So if you're seeing these multiple years of continued therapy, you really want to be on the lookout of those long-term side effects that I had mentioned in previous slides. So overall, one of the main points that this systematic review highlighted is that a lot of patients responded really well just after a single dose of ketamine, and had some sustained effects of decreased suicidal ideation and some depressive symptoms that were continuing within the first 2 weeks. But really mainly within the first week of treatment, they seem to have the most benefit. Given that short time frame window, there is a high risk of relapse of these depressive symptoms, and it would be really wise to maintain an adjunct therapy like your standard antidepressant during this time, or to, if this is a new admission with acute suicidality and depression, to add on an antidepressant medication beginning at that time as well. Because as we know, it takes about 4 to 6 weeks before we start seeing improvement with mood symptoms with our traditional antidepressants. I want to talk about some of that repeated dosing with maintenance therapy again. Not having any really strong evidence for it currently that this would be an avenue to pursue in the future. And it would most likely be beneficial just for that short term when you need a more immediate relief of these symptoms. And a lot of people don't see the benefits anymore after 2 to 3 weeks. And I really want to, again, highlight some safety and tolerability of the long-term treatments in this. So ketamine comes in a lot of different forms, and here's how it was broken down within the systematic review of the different studies. As you can see, most commonly used was the intravenous ketamine infusions with 18 studies. And I have some of the doses that were most commonly used split by each type of ketamine therapy. Most commonly was the 0.5 milligrams per kilogram for the IV usage. This next study here is studies a secondary analysis of a clinical trial that was comparing ketamine infusions to midazolam versed for studying the antidepressant effects for patients with treatment-resistant depression to determine the effects of ketamine on suicidality and symptom severity. Here are the objectives listed in the study. So they wanted to determine whether a single infusion elicits a greater decrease in suicidal ideation compared to midazolam. That was their active control group. The extent to which repeated ketamine infusions elicit a decrease in suicidal ideation, to ascertain whether suppression of the suicidal ideation following a course of repeated infusions can be prolonged with weekly maintenance infusions, and to determine whether the antidepressant and anti-suicidal effects of ketamine are independent of one another. Of note, a recent meta-analysis suggests that reductions in suicidal ideation with ketamine are actually independent of the antidepressant effects and not solely the result of a rapid decrease in depressive symptoms. So here I pulled in one of the figures from this study talking, and this is just shows the symptom severity. So patients were subjectively scoring their own depressive symptoms and then also suicidal ideation. In the white bar graphs, it was very mild and then increasing in intensity to that dark black indicates a really high suicidal ideation risk for these patients. So as we can see on the bar graph, right at baseline, most patients were in this moderate to severe category. And then after just a single infusion, you see that trend start to decrease in severity, and that continues on. Really, after the second infusion, the results maintain a stable level throughout. And thinking about who are these dark black figures that keep persisting throughout, it's most likely these are the patients that have been chronically suicidal with persistently elevated risk level and severity level long-standing. So they might not be having quite the same relief and beneficial effect as other patients. So here were some of the results of the study. So the antidepressant effects of ketamine were greatest at 24 hours post-infusion, and that the maximal decrease in suicidal ideation was actually measured at 7 days post-infusion. So for statistical analysis, the researchers used linear mixed models and found that there was a large reduction in suicidal ideation following the single ketamine infusion compared with the midazolam, and that was statistically significant. And also that 3 times weekly ketamine infusions elicited a decrease in that suicidal ideation severity of scores. But no further changes were seen in scores with weekly maintenance infusions. And going back to our bar graph, you can just see how that kind of levels off, and you're not seeing any great change in effect as we go increase in the infusion numbers, like 5 to 6 over here. Antidepressant effects and decreased suicidality. So from what we've seen so far, it seems like that the reduction in SI is partially independent from the effects on decreasing depressive symptoms. This hints at the potential use of ketamine as a treatment for SI outside of the context of treatment-resistant depression specifically. These findings of reduced SI even in patients who failed to achieve an antidepressant response to ketamine. So for those who don't feel like their depression has improved, they're still seeing a decrease in suicidal ideation in these patients. And like I mentioned earlier with the number of dark black participants on that bar graph, you're not going to be likely to have as great of effect of decreasing your severity of these suicidal ideations for those who have been like very chronic for a long time. So here I just wanted to compare and contrast the ketamine versus like our gold standard treatment for depression currently. So as we can see, that onset time is very, very different and significant. And that rapid onset might be the jump start that patients need to help better manage control of their depressive symptoms. There's also a lot of variety of ways to have it, whether it's intravenous, intranasal, intramuscular, and there's some oral forms as well. There is some hypothesized use for it in acute suicidality treatment, opposed to like SSRIs. And again, I just want to highlight that there is some potential for abuse and addiction with this drug. So some of our key takeaways. This is approved to treat treatment-resistant depression. Typically, patients have to try it and fail at least 3 different types of antidepressants prior to trying this newer kind of interventional therapy. And this comes from based on what insurance companies will approve to pay for. It does have a very rapid onset, and we are seeing this rapid relief of suicidal ideation and severity, along with some, maybe a milder degree of antidepressant relief. And these symptoms are gonna be able to hang around, like the symptom relief will be able to hang around for at least a week. I would be able to confidently tell patients, and then maybe a little bit longer. Again, this variation in symptom relief could be due to the patient's state of mind and mindset going into the treatment, whether or not they feel like it might be beneficial to them. I also wanted to share and note again that this might have some potential use in treating bipolar depression in the future, and more studies should be done specifically focusing on this specific patient population. And then monitoring and patient selection is crucial. Who is going to be the best candidate for this type of intervention? And I do want to just share that the monitoring is around 2 hours that you're going to want to observe them and continuously be taking their vitals to assess if there is any type of hypertensive response or tachycardic response. So I want to thank you all for your attention, and please let me know if you have any questions.